Hello and welcome. I am Bridget Burke, the past president of HIMSS Northern California chapter and the current chair of our education committee. Today, it is my pleasure to welcome you to our education webinar on health equity and the Quintuple Aim. Before we start, I would like to provide you with just a few session operation items. First, we will have a Q&A session with all of the audience attendees at the end of this webinar. So please feel free to post your questions in the Zoom Q&A app, okay, during the session, and also include the name of the speaker that your question is for if it's not a general question. Please note that we will not be using chat for questions. So please don't enter any of your questions there because we will not be seeing them for our Q&A. Just use the Zoom Q&A app on your screen. Also, we will be posting the webinar video and slides on our website later this week. And you will also, all attendees will receive a link to be able to watch the webinar for up to 30 days directly through Zoom. So that will be coming after the session finishes. Now, I would like to introduce our speakers. We have an excellent panel of speakers today. It is truly my pleasure to welcome them. Dr. Alicia Jackson, president of the Lloyd H. Dean Institute of Human Kindness and Health Justice, one of my favorite company names of all time, I think, and Mr. Leon Clark, chief research and health equity officer at Sutter Health, and Ms. Micheline Davis, president and CEO of National Medical Fellowships. Welcome, Dr. Jackson, Mr. Clark, and Ms. Davis. I'm sure that everyone is as excited as I am to learn from all of you today. So Dr. Jackson, please go ahead and get us started.
Great. Thank you, Bridget, and thank you for that warm welcome. So excited to be here with all of you today. And we are going to jump right in. And so why now? Why are we talking about the Quintuple Aim now? So one, I just wanted to give a little bit of framing. I do think that sometimes when people hear Common Spirit, they're like, wait, who? So just a reminder that Common Spirit is the strategic combination of Dignity Health and Catholic Health Initiatives that happened in 2019. With that combination, we became one of the largest nonprofit healthcare systems in the country, serving 21 states, and actually became the largest provider of Medicaid services. So a part of our mission, vision, and values have always been around serving the vulnerable. And with the new institute, which I'm so excited to lead, we really believe that health justice starts with human kindness. And so the institute, named, of course, in honor of our immediate past CEO, Lloyd Dean, which I know many of you know on this call, we really focus on leveraging the science of kindness, compassion, empathy, and trust to advance health equity and social justice. So I think just to level set, I think it's really important that we start with what actually affects health. And so for me, as a family medicine physician, we're often taking care of patients, sometimes 7 days a week, sometimes 24 hours a day. But the reality is of what impacts our individual and community's health is not necessarily majority clinical care. And again, most of you probably know this at this point in time, but what the research tells us is that those social and economic factors, those health behaviors, and the physical environment is actually what has the most impact on health. And you may be saying, well, okay, I think we know that, but why should we care? Why should we care from a healthcare provider standpoint? Why should we care even from maybe an IT or digital standpoint? And I think it's really our responsibility and our opportunity of those of us who are in healthcare to really help others have uncomfortable conversations about why these things are important. And those of you who know me know I love quotes. I'm actually joined today by some of my esteemed colleagues who also love quotes. So I suppose I'll be the one to mention the elephant in the room. And one of my favorites is, a comfort zone is a beautiful place, but nothing ever grows there. So bear with me while we get a little bit uncomfortable for a quick minute. So I had the opportunity working in another large integrated healthcare system a few years ago on the East Coast to really look at what has the research shown around which social drivers have the most impact on health. And what we found is that there were 12 variables in the literature. And we were able to actually track those variables down to the census tract level, so kind of the neighborhood level, and create a social index score combining all 12 of those variables. So what you see on the map on the left-hand side of your screen is that map, that heat map. And maybe there are some of you on the call who love heat maps. I'm like a heat map nerd. And it really shows in the dark red and the dark orange areas, those neighborhoods, right? Those census tracts that have the highest social needs. We then, in that health system, start to look at our health outcome data. So we looked at rates of diabetes, rates of heart disease, rates of depression, rates of obesity. And guess what? Higher rates of all those things in the dark red and dark orange areas. And I think if I was to ask you, well, what are the dark red, dark orange neighborhoods in your community, in your town? I probably, would guess that you all could tell me what those neighborhoods are, right? So the question is, if we intuitively know where these communities of need are, why are they still communities of need? Now, that's maybe another topic for another day, but I really want us to start thinking about that. And just so you know, this sort of heat map is now available across the entire country through the CDC. And so the map on the right is a picture of that, and the link is down there at the bottom. I encourage you all to go and take a look at your own city and town that you live in. So why should we care? So there's a moral imperative. If you look at the number of individuals who die every day in this country based on disparate care that they receive because of how they look or where they come from or their socioeconomic status or maybe the language that they speak, it's equivalent to a 747 falling out of the sky every day. Now just think about that. If a plane fell out of the sky every day, what the public outrage would be with the airline industry, right? I actually think the airline industry is probably one of the best examples of quality assurance that we have. So there's a moral imperative for us to think differently about equity. But there's also a financial imperative. So two studies that I always like to look at is a study that was done by the Joint Center Health Policy Institute that said costs between 2003 and 2006, based on health inequalities and premature death, was $1.2 trillion, And the Urban Institute projected that there was between 2009 and 2018, that we spent over $300 billion on healthcare related disparities. So just think about that. Prior to COVID, our GDP, our national GDP, healthcare took up about 18%, which was still unsustainable and almost double what the next industrialized country's healthcare expenditure from a GDP standpoint. Since COVID, we are now, depending on which study you look at, between 22 and 24% of the GDP. It is financially unsustainable, right? So there's really a financial imperative for us to think differently. And often when I'm giving these talks, especially to providers who may not necessarily be in direct patient care, and let me be clear, I intentionally call us all providers because those of us in healthcare, no matter what job we do, we are helping to take care of people and communities, right? So people are always like, well, where do we start? Where do we start? And so often with my IT colleagues and my research colleagues, it's like data standardization. Now, this is one of my favorite cartoons. You all can see this here, but we talk about standardization and instead of standardizing and minimizing, we just end up adding, right? And so I think that's a key place for those of us who are involved in looking at data, collecting data, to really think about data standardization, especially as it relates to race, ethnicity, language data, sexual orientation, gender identity, and social determinants of health. So ultimately, my charge to all of you is to think about, how do you get activated? One of my favorite quotes from Edwards Deming, who some will say the father of quality improvement, every system is perfectly designed to get the results it gets. So just think about that. we have systems in place in this country that perpetuate disparity. And so I actually think we need to design new systems. And some of the ways that we can think about doing that is first, of course, define the problem, right? What's the problem to be solved, but then create the strategy to solve it, resource the operations. We have to make sure we're implementing accountability when it comes to equity work. And then ultimately, going back to the data conversation, we have to measure outcomes. And my colleagues are going to talk in more detail about some tangible ways that we can do that. So with that, I'm going to turn it over to Leon.
Thank you, Alicia, and good morning, everyone. So you did a perfect job, I think, of framing the why and why not. So I'm going to move us a little bit beyond that, and I'm going to try and move quickly so as to allow time for dialogue. Let's next slide here. Let me go back one. I just wanted to say a word about Sutter Health. Sutter has the privilege of serving about 3.5 million patients across Northern California. The way I think about it is we serve some of the wealthiest zip codes in California and some of the poorest and everything in between. What you may not know about us is that our patients are majority minority, and what that means for us is that our drive to achieve equitable outcomes is not only the right thing to do, it's the smart thing to do. It's the strategic thing to do in that I consider it differentiating. And of course, as Alicia alluded to, it's the financially prudent thing to do, especially in these times where most healthcare systems are struggling financially. Today, we're talking about the Quintuple Aim, and I understand that, but one of the things that I've tried to do and ensure in the context of our work is to ensure that the needs of patients are kept at the center of our universe. From my perspective, the needs of patients must always come first. We've tried to codify that in a health equity pledge that we make to our patients. That is, all patients who receive care at Sutter are afforded the highest quality care that's available. We're focused on the unique needs of patients and the communities in which we operate. And our line of sight, our ultimate line of sight, is to generate equitable and optimal outcomes for all patients that we serve. I consider myself fortunate in that I have secured the support of Sutter leadership. In fact, it's rare that I get any pushback at all about the need to advance health equity, the need to invest in health equity, and to move with alacrity. What often comes up in the conversations are three things. Number one, where do we start? To the point that Alicia was making earlier. Number two, how do I fit this in with everything else that's going on in our universe? Our plates are full. And number three, what really works, and what investments should we be making? So I like this quote by Arthur Ashe, because this, in essence, encapsulates what I tell people. Start with where you are. I think the most important thing is that we get started. Use what you have. There's an expression I've heard, I won't get it exactly right, but it goes something like, when you focus on the things you have, rather than the things you don't have, you often realize that you have enough to get started, and that's the goal. And then the last part of this quote is, do what you can. And what I always tell folks is, look, settle for progress rather than perfection. The enemy of good is perfect, and we should do what we can with the resources that we have. So I actually think that there is a pathway to progress, a framework, if you would, for health equity improvements. If someone were to ask me, well, what investments do you need to make, or should we make, in order to advance health equity, I would point to these things. These are sort of foundational capabilities, in my view, that enable the advancement of equitable outcomes. The first is data and analytics. We refer to it here as metrics and insights, but we have a lot of data. And as Alicia was pointing out, it's essential that we start to be disciplined data collectors, serial screeners, so as to understand all of the needs of our patients and communities that we serve. But inside that data is intelligence, it's insights that underpin health equity solutions. So I think we have to move beyond just admiring the problem to actually doing things, developing interventions that improve the health of patients and improve the health of populations. So we call that solutions and advocacy, and I'll share a little bit later how we're thinking about accelerating innovation. The next thing is workforce readiness. And many of us, and I suspect many of you who are watching today, have really invested in things like unconscious bias training, cultural competency training or humility, empathy, and things of that sort. What I've learned, or what we've learned, is that it's necessary but not sufficient to really prepare the workforce to deliver consistently culturally competent care. We have to also invest in diversity, equity, and inclusion, and a culture of safety. So these things taken together creates, I think, the kind of environment that enables the consistent delivery of care that's presented with humility and empathy. And the last thing is community engagement. So given that 80% of healthcare outcomes are determined in part by things that happen outside of the healthcare system, I'm not sure how we generate sustained gains without investing in community, becoming a trusted partner in community, not to replace community-based organizations, but to complement what they're already doing, to work alongside and amplify those capabilities. I wanted to just spend a few minutes talking about dashboards. As Alicia said, and many of us have already done, started with data collection and standardization that typically translates onto a dashboard or some kind of report that's circulated across the organization. And I think that is a wonderful place to start. But again, it's necessary but not sufficient. I think there is efforts beyond the dashboard. And the way I think about it is, who's looking at it? What questions are being generated from the data that's being shared? And perhaps more importantly, what are we doing about it? And so I think of dashboards as delivering on three things. Number one, it is a heat map, as we talked about earlier. It helps us prioritize our efforts. Wherever you see red on this version of the Sutter Health Dashboard means that there's opportunities to do work to improve healthcare outcomes for individuals and for communities. And we should do that work with alacrity. There's also green on this particular dashboard, which means that somebody's doing something right in our system. And so in that sense, it's a learning platform. And the idea is to identify those positive deviants, bringing groups together, those that do it well and those who don't do it as well, and allowing opportunities for us to learn from one another, what works in one environment, assuming that we can identify those positive deviants should be applied and scaled to other parts of the organization. And then the last part, of course, is it's an accountability framework. Look, carrots and sticks are coming. I would rather offer carrots to get people to do the right things, to fill in accountability and a responsibility for ultimately improving healthcare outcomes for patients and for communities. The last slide I'll share concerns the cycle of innovation and how to accelerate it and apply it and scale it across your system if it works. From our point of view, we've decided to engage the whole of the Sutter Health community in accelerating innovation. So we actually invite them to submit proposals that address measures on the left-hand side. We know that access is a problem for everybody. I like to think of it this way. There is no quality without access, and there's no equity without quality. And so it starts with access. We have to develop new ways to extend access, information, guidance, and care to populations, particularly those populations that have been historically marginalized. Care transitions, patient experience, community engagement, workforce readiness, and clinical outcomes are also targets for our interventions. We try to use those or target those in the context of our priorities, which are maternal and birth equity, mental and behavioral health, chronic disease equity, diabetes, hypertension, etc. The goal, though, ultimately is to engage all of Sutter Health in this work, engage inside and outside of our organization. The magnitude of our problems require an all hands on deck approach, and that's what we're trying to do. This program, this approach is overseen by the senior leadership of Sutter Health, who get to decide which proposals are accepted, and then the approach is to think big, start small, but move very fast. I'd like to say it this way, the patients are waiting while we're debating on what to do. And they deserve our very best, and they deserve a situation where we're moving with alacrity to solve their problems. So with that, I'll pass it to my colleague, Micheline Davis, who will take us the rest of the way.
Thank you so very much, Leon and Dr. Jackson. You have so beautifully set the stage for this discussion. So I'm just going to dive right in as we continue this dialogue. And I hope that this audience is getting as much out of this as I am, because I undoubtedly am enjoying hearing about the brilliance of others. I want to start this element of the discussion by really focusing in on the importance, yes, of advancing health equity in principle, but also of ensuring that there's that combination, that mention of ensuring that there is diversity within your workforce. We already know that racially and ethnically diverse health workers improve outcomes for all, that it's not just for those individuals who are Black, Indigenous, or persons of color. Although we do know from, I'm going to use my quote as well, from a quote from Dr. Martin Luther King, happy Black History Month, everyone. It is the 1st of February. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, right? So I want to acknowledge the fact that he had to say that so long ago and that we're still finding it true today. So I want to make certain that we mention the fact that for BIPOC individuals, Black, Indigenous, persons of color, yet again, who have received medical attention in the continental United States, research tells us that they have likely experienced how inequitable our healthcare system is at a personal level, right? So why am I saying this? Why am I mentioning this? Because it is all important that you, the industry leaders, the institutional change agents, the change makers, the trailblazers, that you understand that we must not leave out of the equation the effort to ensure that we are also diversifying the clinical workforce. Why do I say that? Well, I'll tell you this. Because the slide before you reiterates the fact that research has told us that the studies show that when the healthcare clinician is a member of the BIPOC community, that when they are in particular with a BIPOC patient, what are they finding? They are finding that there's actually more time spent with the patient. We're finding that there are questions that are asked and tests that are ordered more frequently than if, in fact, their clinician is not of color. We find from the evidence, not me, this is not me saying this, this is literally the research that's been done to date, that there's more consideration around strategic planning for medical insurance, because you just heard my colleague Leon talk about the all-important effort and point of equitable access. We find that when, in fact, we have individuals who are from diverse backgrounds who are coming together, especially those who are from those communities that have been marginalized historically, disenfranchised historically, underinvested in, and under-researched, we find that they approach the profession itself with a higher level of cultural humility, and that higher level of cultural humility makes its way into their patient interaction. That they bring to it a consideration of a patient's customs and values, of families, of their spirituality or their traditions, They understand that if in fact you come from a Cuban background and refried beans is very important, that if in fact you are Dominican or quite frankly, if you come from a rich cacophony of many different cultures as my family is, then we understand that your traditions mean something to you. And so it is not merely just saying, do not do this, but rather do this with an eye towards ensuring that there are healthier alternatives. And quite frankly, what we have found at National Medical Fellowships, which I'll take the opportunity to talk about more now, we have found that our scholars are more likely than their mainstream counterparts to want to return to the areas that are most underserved, those that are medical deserts, those that are medical deserts in both rural and urban areas, that they are more likely to do so than their counterparts. And so as we take a look at that, it's really important that we also make certain that we understand that on the patient experience side, we find that patients themselves tend to be more likely to listen more intently, that they have more candid conversations, they open up about those things we've just discussed, that they ask more questions, they are more likely to follow the screening and the treatment recommendations all the way through, right? And that they report feeling seen and understood. And why do we even think that this is important in actually attaining the quintuple aim? Well, we think it's important because of the lifelong aspect of the weathering of racism. There are so many of you who understand that, quite frankly, so many of us suffer from living under a high intensity of chronic stress, which is what the experience of racism is, and that even science evidences the fact that it shortens our lifespan, right? It affects our cells, right? That we age more quickly as a result. The aspects of political disenfranchisement, like, oh, I don't know, right? Voter restriction, community disinvestment, gun violence, and finally, might I mention, police brutality. You may very well be aware of the fact that back in 2018, the University of Pennsylvania put out a study that literally lends itself to the fact that African Americans, that when they in fact witness an effort of police brutality on another African American, that they report upwards of 3 months of poor mental health days. And that is completely with disregard to the proximity of the location. So if it happens in Rice, Texas, they feel it in Albany, New York at exactly the same way, and whether or not they know the individuals. So what can institutions do in order to make certain that there are environments that really ensure that individuals are given a chance to attain the quintuple aim to really advance health equity? Well, that is why National Medical Fellowships exists in and of itself, because of the fact that we have been doing this work for the last 76 years. Since 1946, we have been making certain that there are diverse clinicians from backgrounds that are non-traditional in the field. And so as we are putting out more and more alumni, like Dr. Jackson, who is one of our 32,000, we want to make certain that institutions understand as well that when they attempt to recruit them, that they already are at a point where they understand what it takes in order not to just recruit, but to retain and matriculate, to promote and to keep, right? So I want to really encourage institutions to acknowledge and actively address their unconscious and implicit bias, right? Make certain that they are examining it and taking a look at it in their hiring practice, their training, their management and promotion of the workforce, right? Are we in fact being as transparent as we need to be? There needs to be some kind of internal analysis that looks at your current policies, your practices, your processes. We want to make certain that everybody has an opportunity to show up and thrive, not just to survive. Are we ensuring that we have equitable access to career advancement opportunities? And quite frankly, are we ensuring that we are advancing accountability based on our data and our metrics? Are we not just collecting the data, but are we also going back and saying, listen, here is something that we really need to look at, and are we holding individuals accountable for these things, right? So now I want to thank you for your time, and I want to shoot this back to Dr. Jackson so that we can begin our wondrous roundtable. Dr. Jackson.
Thank you, Micheline. I always feel like I just received a word whenever I hear you speak. So thank you. And thank you, Leon, for your comments as well. I'm actually going to toss it back to you, Micheline. One of the things that I tend to hear when we start talking about the quintuple aim is, we haven't even achieved the triple or the quadruple aim. So why are we adding now another additional layer? So what's your response? Have you heard anything in that similar, and what's your response if you have?
Yeah, first of all, thank you so much for the great question, because it is, in fact, and yes, I have heard it. As you are aware, I come to National Medical Fellowships, this national foundation, from a career in academic medical center systems. And so what I will tell you is that when I hear it, and I do hear it, especially because of the fact that we're still in the midst of a pandemic, that folks are still fighting burnout, right? So pretty much like, I'm still tired. We're dealing with physician and nursing shortages, right? What are we going to do about all these things? I like to hearken individuals back to when the triple aim was introduced. That 14 years ago, right? Which may to others seem so long, but was really just yesterday. There was a lot of resistance in the industry about it. And to make certain that individuals understand that, listen, I don't advocate for the quintuple aim lightly. I really take it quite seriously, because it's so incredibly important to know and understand that, yes, it took us to this point to make certain that we are embedding equity and trying to do all of these other elements. The reason why we haven't actually attained the triple aim in and of itself is because of the fact that equity was left out of the room, much less off the table. So it's really important that we build these systems and these structures and our reviews and our aims, right? As any scientific researcher will tell you, your aim has got to be correct in order for you to attain your goal, that we are literally layering in the element now at the very beginning, right? That we are making certain that all of our efforts are thread through a lens of ensuring equity at the outcome, right? So thank you for the question. And I think I'm going to turn my attention over to our friend Leon, if that's all right with you.
Okay.
Leon, thank you so much for your rendition of the tremendous work, and kudos, my friend. I've been in a healthcare system. I know it's hard, right? Change making is hard,
Yeah.
especially for health equity. So I'd love to hear from you a little bit, because you're right there, you're boots on the ground, you're on the field, about all the things that you talked about, right? What has been the most difficult for you? Not just in the conceptualization or the strategic planning, but then the implementation of its execution.
Yeah, I think it for us it boils down to two things. Number one, bandwidth. We're all terribly busy, and the other is resource assignment. So the healthcare industry, generally speaking, most health care delivery systems are struggling financially. And so, setting aside the resources or identifying incremental resources that are necessary to invest in health equity, I think has been the real challenge. But here's my response to it, and part of it is, I think, a practical approach to sort of the problem. Number one, I would say, as Arthur Ashe pointed out, start where you are and use what you have. Do what you can. And it's often that there's resources available in the system. They may not be specifically identified for health equity, but they could be leveraged to improve the underlying factors that contribute to it. So think about community benefit or community health that's already making investments in community. How can we think about investing differently, targeting those things that contribute to disparate outcomes, social determinants of health, building or investing in those communities. Just as an example, in our particular case, I think about the intersection between health equity and digital transformation. Many of us are making investments in the digitization of healthcare. How do we use that aim to extend reach to marginalized communities, through some kind of digital channel? So that's essentially how I do it, is to try and take advantage of the things that are already happening that could support our aim to improve access and equitable outcomes. So I think the next question is mine. I'll turn it back to you, Ms. Shalane, if that's okay. So I think we've all, many healthcare leaders have been thinking about how to diversify the workforce. It's particularly challenging now with such a low unemployment rate. But what practical advice, suggestions do you have for large healthcare systems who want to diversify their workforce, but tend to be struggling in that regard?
Yeah, first of all, thank you so much for the question, Leon. Just really incredibly important that individuals and entities are actually thinking about this. So I like to tell them to do a variety of things, right? It really is something of the soup. But I want to begin with the first ingredient, and that is do not wait for the effort to recruit to begin cultivating an environment of belonging and inclusion. Right? We know that that belonging is that feeling that comes from diversity and inclusion efforts, right? We know that. And so you really need to make certain that the institution to which you are trying to recruit individuals can literally say, this is where we are in our equity journey, right? Whether you are well advanced or just beginning, right? But be able to literally say, we've already launched our internal assessment. We're already looking at our practices, our processes, our protocols, right? Those things that I talked about a moment ago. 3, that we've begun to take a look at our composition as an organization, and we recognize that while we have a high number, right, of diversity, that it tends to be lower within the organization, and we've already working with our human resources division in order to assess why that is and what we need to do about it, right? So it's really important that all of this happens prior to the recruitment effort for a diverse candidate. Why? Because so often institutions have made it incumbent upon the candidate to bring about an environment that welcomes diversity once they get there, right? And that's not what they want. What we really want to see is the fact that individuals are welcome to environment so that their skill base can shine, right? That they don't have to worry about trying to survive, but that they're really giving a platform to thrive. So that's really important. 2, they really need to be in partnership with NMF. National Medical Fellowships literally make certain that our partners are able to access and to be availed to our 32,000 alumni. We have clinicians practicing all over the country and internationally. So when they say, well, we can't find a candidate, I'm like, well, where are you looking? Right? So it's a really important element that they also take advantage of that, that opportunity and to understand what partnership looks like. 3, right? Understand that these are also individuals that are really worth their weight in gold. And so, yes, it may in fact be that you need to revisit your budgetary constraints around wanting to attract a candidate who is going to be really looked at for this same type of position across the country. And so really make it worth, right, that opportunity. But I think, Leon, that it fundamentally comes down to what I said earlier. The great thing about our scholars, right, like our alums who have graduated, every single Surgeon General of color in the United States is a National Medical Fellowships alum, right? That's just how we tend to do it. So if you are interested in the best of the best, then it just makes sense that you are already looking at these things within your institution. And again, our scholars have a greater tendency to literally want to go back to institutions that are within historically marginalized communities. So then what is your institution doing in order to better the community as well, right? Lead with that in your next effort to recruit.
Thank you. I appreciate that response. You can't see, but I'm writing notes, so I appreciate that. Thank you.
Happy to. So Alicia, I have a question for you, if that's okay. All right. I love the title of your new role. I love everything about it. And I will completely confess, I'm a Lloyd Dean fan club girl. I'd love to hear from you about why it is that, you believe that, and the institution believes that human kindness is a requisite to achieve health equity.
No, thank you, Micheline, for the question. And again, thankful to National Medical Fellowships as a recipient. As she mentioned, I am alumni of this amazing program and was blessed, quite frankly, to have received support from your organization while I was in medical school. So thank you so much. So I think this is really interesting. And I'm going to talk a little bit, since we're talking about the Quintuple Aim, about the provider well-being well-being piece of it, which as all of us hopefully on the call know, that's the fourth pillar, when it was the quadruple aim. And I think we really need to be thoughtful about what's going on with those of us who are caring for others across our organization. You know, prior to the pandemic, we already knew that healthcare providers were at increased risk for suicide. Since the pandemic, that has increased dramatically. As a matter of fact, Mental Health America did a couple of studies, one about 6 months into the pandemic, and then another about a year into the pandemic. And what they found was some of the questions, upwards of 70 and 80% of the healthcare workforce, so that included physicians, nurses, EMTs, respiratory therapists, occupational therapists, even hospital administrators, were experiencing some sign of burnout. So just think about that. If 80% of our workforce is experiencing some sign of burnout, how well are we really taking care of the people in front of us, right? And when you look at the research, and this is the thing that I always tell people, you know, there is decades and decades and decades of science around kindness, compassion, empathy, and trust. So when you look at the research around what mitigates some of those factors, what actually helps with burnout, yes, meditation, yoga, stress relief, those things are all good, and those are evidence-based as well. But what we really know is that we have to change the culture, right, of the work environment. So I can go and meditate as much as I possibly can, but if I'm walking back into a toxic work environment, it's not going to matter. And so what's the research around how do you improve work environment, right? And guess what? The research tells us, going back to some of the comments that you just mentioned, Micheline, about creating a culture of belonging, the research tells us connectiveness, making sure people feel like they are seen, making sure people feel heard or are heard, is evidence-based. Having caring conversations with individuals. Having caring conversations with individuals. So I think it's really important, especially at this time in our lives, to really be thinking about how are we creating a culture of kindness? How are we making sure that people feel listened to, that they are seen? How are we validating people's lived experience? Because again, we know that by doing that, we can improve work environment, but reduce rates of depression, reduce rates of anxiety, and you know, be really thoughtful about increasing the level of civility, which again, if you look at some of the social science data around that, especially in America, we are at a time where we have the lowest amount of civility in this country in the last 50 years. So I think this is an important time for us to think about how do we bring that social science into our healthcare delivery workforce, not only for our communities and the patients that we're serving, but for each other.
So by my clock, we've got about 11 minutes left. This might be a good time, I think, to move into an open Q&A session. I see that there are two questions in online already. And these, I think, are for anybody. But the first question is this, and Micheline, maybe you want to start, and Alicia and I can amplify if you wish. But what are your thoughts on increasing leadership at the C-suite level, or diversity at the C-suite level?
So I've got tons of them, and happy to answer this, Leon. I mentioned that prior to coming to NMAP, National Medical Fellowships, I was actually in academic medicine. I was actually an executive vice president and chief corporate affairs officer, and had been both the first woman to ever attain that level and the first person of any color. So one of the ways in which I like to really encourage institutions is to first do an examination of the way in which they literally promote up in their organization, right? oftentimes what happens is that one of the currently existing executive vice presidents or senior leadership members has a tendency to think of someone that they like a whole lot because of why? Because they remind them of themselves, right? How many times have we been in meetings and we've heard Tom say, I really like John, he really reminds me of a young me, and so I want to give him this opportunity, right? So one of the things that I really recommend is to actually officially create a stretch assignment talent pool. That literally what you're doing by virtue of doing that is ensuring that you cannot lean back on the default of, oh, I didn't know that you were interested in doing something more within our organization. Rather, you create almost an application process and have individuals have an opportunity to raise their hand about whether or not they would like to be considered for any stretch assignment or project championship across the institution. And by virtue of that, what you actually are doing is enabling individuals to come up out of, right, the four corners of their job description and to actually do things that benefit the entire system enterprise-wide. Why do I say that? Because it really helps to ensure that there is so much more transparency, about the fact that the opportunity exists. It helps to make senior leadership so much more aware of the talent within the existing talent pool of the organization, right? And it really makes certain that things are much more equitably done, especially when there's an evaluation process that has actually been officially designed, right? So that it removes the subjective aspect of our own natural human bias. It's so incredibly important. Right. And then, quite frankly, once that promotional opportunity comes up, you almost kind of do the same thing. Yes, you post it, of course, but this time you don't post it because you've already had a conversation with John telling him he's going to get the job. Rather, you go back to that talent pool, right? You encourage folks within that talent pool in particular to, of course, apply. You'll be very surprised at what you will find out, right? And as a result of that, it just opens up a world of opportunity in institutions where the doors of opportunity have been siloed for so long.
Yeah, the only thing I would add is, organizations that do it very well. So if you look at their the representation of women and minorities in leadership, those that have done it well have done it with intent. They don't rely on serendipity, and it starts early in the process. I would take a close look at your leadership development pipeline to make sure that that's diverse, that we're intentional about giving those candidates opportunities to experience new learning opportunities, that they're supported with mentors and advisors who could help them by pointing out landmines, if you would. So I think the process just has to be a little more intentional. I rail against sort of the post and pray strategy, right? We post a job and pray that a minority candidate will apply. That doesn't work. We have to be very intentional, and we have to go out and find highly qualified candidates. They exist. I always reject the notion that we couldn't identify any well-qualified minority candidates. And so I don't believe that's true. I think we have to go out and search for them. The other thing I wouldn't do or wouldn't support is a lowering of standards. I don't think that helps anybody. I just know, because I know a lot of minority healthcare leaders. I know that they exist in ample supply, but your organizations have to be much more intentional. Maybe I'll leave it there. Alicia, I don't know if you have anything you would like to add.
Thank you. Completely agree with everything that's been said. I fortunately have been blessed to have worked in 2 large integrated health systems that, quite frankly, have done an amazing job in diversifying their C-suite and their board. So that would be the one other thing that I would encourage people to think about as well. But I also want to caveat that it shouldn't stop there. And so going back to Leon's comments about leadership development, again, when you look at what some of the research shows, especially for women of color, highly qualified women of color who are very operationally excellent tend to get stuck at director or AVP levels. And I think you might say, well, that's great that they're making it to that, but that's a critically important point, because in order to start being considered for C-suite, right, in most organizations, there's a level of progression. So we have to be really thoughtful of looking at all the levels from a leadership standpoint. And to Leon's point, making sure that we're helping to develop those leaders beyond director, AVP, into those VP or SVP, whatever your hierarchy ranking system is, so that they are even eligible to be looked at, right, for some of those C-suite opportunities.
And can I add to that, Leon, I just, before we even leave this question, because, you know, one of the elements that I tend to I guess I rail against is just believing that the BIPOC candidate needs to be mentored. I think it's really important that we train as well our majority managers. They need to be trained on, quite frankly, the nuance of how to control your implicit bias, right? When you have a diverse team, right? How to make certain that you're checking yourself first thing in the morning in order to ensure that you're listening for your own language. And so I want to make certain that I mention that as well, because those individuals need that mentoring as well. When we only mentor the persons of color in a majority institution, we other them instantaneously. And so really important that we not just do that. Thank you.
Yeah, we're almost at time. I want to get to one perhaps final question, and it concerns the use of predictive analytics. I think we all in some way talked about the importance of data capture, data standardization, and analysis. But the specific question is, what are your thoughts on leveraging predictive analytics enriched with social determinants of health data to improve healthcare outcomes? Alicia, maybe if you want to start with that.
Yes, thank you, Leon. So I have actually had the opportunity to work with a couple of different predictive analytics tools and vendors as it relates to social drivers of health or social determinants. And one, I think they can be useful as a tool. So let me just start there. However, I think we all have to recognize that all of these AI and predictive analytics tools are created by humans, right? And as Micheline mentioned, we all have implicit biases that we bring to the table. So I think we have to be really careful of recognizing these tools just as that. They are one piece of a puzzle. And we have to remember, as it relates to social determinants of health, that ultimately we're talking about someone's lived experience. And so just because someone may live in a community that has a high social index score, for example, doesn't necessarily mean that they are experiencing some of those drivers. So we still have to overlay that human connection aspect and make sure that we are really interacting with the patient and the individual in front of us, you know, asking them directly what are the needs that they have, and then, you know, addressing them, you know, in a goal setting way where we are leveraging that individual as a part of building the solution. So again, I think they're useful as a tool, but we do have to be very mindful that we are still talking about people in their lived experience.
So I see Bridget has rejoined, which means that we're technically out of time. And apologies. We really wish we had more time to address questions that you might have, but Bridget, over to you.
Yes, thank you. Thank you, Dr. Jackson, Mr. Clark, and Ms. Davis for sharing your amazing expertise with us today. We have run out of time, but I think this is just going to be the beginning. I think we will have additional sessions on this. We absolutely need to be talking about this more. I would also like to thank all of our attendees for joining us and taking the time to learn about this important topic. And hopefully, you all have been inspired to move to action on it. We will be posting the video and slide deck for this webinar on our website. I will put the link into chat now. You should see it there. It's also in the event lobby space, so you can get the resources there. I hope that you will join us next month as well. We have our 10th Annual Innovation Conference and Expo on March 23rd. So thank you again for joining us today. I hope to see all of you again soon and have a great day.